with us, but I will let the others do their introductions. So, hi, my name is Chris Guello, GP in City and Hackney. I'm Nell's CBD clinical lead. I'm also a clinical lead at the Clinical Effectiveness Group. Joined today by Dr. Michael Hanlon. Mike, do you want to do an introduction?
Hi everyone, my name is Mike Hanlon. I'm another one of the clinical leads at the Clinical Effectiveness Group, and I'm also a GP based in City and Hackney.
Thank you. And Krishna has disappeared off the screen, but Krishna, do you want to do an intro?
Hi everyone, my name is Krishma. I'm a clinical facilitator within CEG, and I overlook the APL tools launch and management. Thank you.
Joining us today, we also have other members of the team. We'll give you a outline of who they are for your area as we go through this, but I will kick off. So once again, thank you everyone for joining us today. We're here to talk about the APL-AF tool. This is a tool to help with identification and recognition and management of patients with AF to best optimize their care. This is developed by the team at the Clinical Effectiveness Group, and it's pretty helpful to understand a bit more about who that are and what they do. So the Clinical Effectiveness Group is based in Queen Mary. It serves the whole of the North East London ICB. The aim over the last 30 or 40 years has been to support the effective and equitable primary care in North East London. That's means supporting GP practices, supporting the commissioners in the development and the monitoring of services, and similarly with public health as well. I'd say it's based at Queen Mary University, primarily getting funding from the NHS and local authorities alongside from research, and that's been the benefit of working with at the Queen Mary University, is having the input of academics and bringing expertise into the fold. Essentially, though, we are GPs, we're health data scientists, we're analysts, and we're facilitators. You're probably most familiar with our facilitators, and to some degree our GPs as well. Through that and through those relationships, we have been focusing on health inequalities, and that's led to us with the work that we've been doing in supporting primary care and in North East London to lead to some fantastic improvements in care, but also developing research that has been of not only national but international significance as well. And this builds on the approach of a clinical effectiveness, which essentially, I think you're probably all familiar with the term of quality improvement, and this is something which sits alongside that improvement methodology. It takes a golden thread which runs through data into action, and to do that, what we need to start off with is by having good quality data that identifies coded entries, disease metrics, patient information, and helps us to think about the population as a whole. Now that then allows us through the entry into those templates which have coded drop down lists to make sure that we're getting that good quality data. It allows us then to scrutinize the data of the population health data. It allows us to develop the searches that help us to identify changes and differences across populations. It helps us to look at how practices are doing in terms of their QoF data, in terms of the local enhanced services. It helps practices crucially with their patient management in terms of call recall, in terms of disease registers, and identifying the opportunities for improving health of patients. That data that is through the coded data entries and the templates that's pulled out through the searches then goes into a visualization tool, essentially a dashboard that allows practices and commissioners to monitor how the health of the population is doing, and helps to motivate improvement and change. That is also supported by software tools, one of which we're talking today. We'll go into more detail on that in a moment. But crucially here, one of the big things that helps to practices in the data quality and the searches and in the indicator achievement is through the facilitations. That's facilitation through our facilitators that work very closely with you in your practices, but also in terms of the expertise that's provided by people like myself and Mike and others who work within CEG and with the practices to provide the expertise on how to make that improvement, how to take that data and use it to drive improvement in healthcare. This is essentially showing that there's not a one thing that's going to make a difference. It's not the APL-AF tool which is going to drive the improvement, but there's a system approach rather than a standalone tool. We've been doing this for a number of years, and it's both through our work from the 1980s onwards that has allowed us to develop this approach and show the success over time, which has led to North East London making the achievements they've had, making the practices, supporting the practices with their workload, supporting the health system in terms of the financial achievements as well. So there's a whole systems approach here that goes hand in hand, and I think it's really crucial to be able to work in partnership with yourselves to make those improvements. And so we work very closely to identify how we can utilize the tools that we have at our disposal to make the work in your job much easier. So that comes on to AF. I said one of my roles is around cardiovascular disease. And when we think about cardiovascular prevention, we think of the ABC, we think of AF anticoagulation, we think of blood pressure control, we think of cholesterol management to try and reduce the burden of cardiovascular disease in our population, which is still very, very high and a big issue for our patients and how they live their lives and how they live in their communities as well. Within that, AF is a large factor in cardiovascular disease in terms of strokes, and it's responsible for 1 in 5. There is a solution, but to potentially hearing that anticoagulation reduces the risk of strokes by more than half. But the problem there is that not all patients who require them actually receive them, and that's particularly bad for those people who do then go on to have a stroke, because AF related strokes are often much more severe with a greater mortality, but also with a greater disability if an individual survives. 2 in 3 patients who are prescribed the anticoagulants in combination with antiplatelets receive those antiplatelets for longer than 12 months. So they are one of the things that we need to understand with our patients is whether they have the right medications, whether those medications are optimized. So making sure that we're delivering the best care in terms of the medications that we're giving them and making sure those medications are appropriate for them. I mentioned about the ABC, so it's also important to think about for patients with AF whether they have also got their other activities to help reduce their cardiovascular risk. That's particularly around blood pressure and lipid lowering therapy as well. So the APL-AF tool helps you then to optimize your medication, so it helps increase anticoagulation in the population to prevent heart attacks and strokes. It reduces the patients who are on dual therapy for longer than they need to be, which will help reduce the incidence of major bleeds. And it also shows you the warfarin users who might benefit from a discussion about whether they'd be better off switching to a DOAC. The other aspect of the tool is it helps to tailor your approach, so you can then see the other relevant medications, see their other comorbidities, look at their vulnerabilities, and for example, look at their blood pressure for the recording for each patient. The APL-AF tool's been around for a number of years now. It was first launched in 2016. It's launched in Redbridge. And through that time, we've seen some big improvements and had some success recognized as well. So in Redbridge, the anticoagulation rate improved through the use of the tool. So we say that went from 77% to 83%, but in real numbers, what that meant was 290 additional people on anticoagulants, and that resulted in an estimated 30 strokes prevented over the 5 years. Across Nell, that allowed us then to become the best performing region for anticoagulation, and this was recognised through the HSJ and the AF Association Healthcare Pioneers Awards, where they were winners in 2013. through BHI, this pharmacy initiative, it was the awards were for this 94% anticoagulation and a 52% reduction in dual therapy. So when it was expanded to BHR, the anticoagulation rate increased, the reduction in dual therapy was improved through a joint piece of work with pharmacists. And so, as I said before, this isn't a plugin, but this is something that works alongside people within their practices and how they work. And that was what was recognised through the HSJ and the AF Pioneer Awards. So what's new? Why are we bringing this update to you? So I think it's always important that we make sure that we're refreshing things in terms of knowledge and how things work and are being used. So we need to make sure that all users are aware of how to best get the functionality out. Alongside that, it's important that you make sure that you have the latest version of the tool, and there has been some changes in this. The first being is that we've moved now to SNOMED codes to make sure it's up to date with how everything else is coded in you're looking at our primary care data. There's also an additional functionality benefit on that in that there is a ability to export a patient list that you can then use in Accurix or others. So it allows you to put that into Accurix, or you can create a list that you can then use to reference in a different way. All of this is tying into making sure there's better usability. Alongside that, to make it easier, we've also created a new step-by-step user guide that follows the same format as our other tools. It should be something that you're familiar with, but we've created that as a reference that you've been able to utilize. I say it's important, again, just to emphasize this, that all users upgrade to the latest version of the tool. If you've downloaded it in the past, you should be on your mailing list, but they may not be, and sometimes these do get spread through the practice. So it's important that if you are using the tool, or that you have your peer, colleagues who are using it, that they update to the latest tool. We'll link to the best form later on in this, but I think it's probably enough of me talking, so I'm going to hand over to Mike now to see the tool in action.
Brilliant, thanks, Chris. So let me just share my screen. Okay, so can you see that, Chris?
Yes. Is there any chance you can make that bigger?
Bigger? Okay, so I can zoom in, or I'll tell you what, I'm just gonna unshare and do it in a slightly different way. Is that any better? I can zoom in otherwise.
That is a bit better. We can just, there's bits missing off it, but I think you can scroll across when you get
Fair
to those
enough.
parts.
Yeah, I can scroll because I've got quite a big monitor, so I think then when I try and share on Teams, it does go a little bit small. So this is kind of what the APL-AF tool looks like when you launch it. So you get the overview screen, and there's the option to import the report that you run within your clinical system. So when you go to the link and download the tool, it'll ask you whether you're running EMIS or System 1. If you're running EMIS, it's a slightly different version that has the search and report that you'll need to import into EMIS. You run that, export the report as a CSV file. The instructions for how to do this are included in the user guide. And once you've got that, then you come into the tool, choose which clinical system you're using, and then use the import function to import the CSV. When you download it, the tool, it'll come with some pre-populated folders to allow you just to keep things organized. So I'm going to import some dummy data here. It's designed to look quite realistic, so it has names and things like that, but just to reassure everyone, it is in fact dummy data. So once you import that in, you get this overview screen. So that brings up all the patients that are on your AF register, and it organizes them from top to bottom by their CHA2DS2-VASc score. So if we have a look down, it'll have all the patients that are in the register here. There's a nice handy summary box over on the side here, which gives an idea of the size of your register and a breakdown of some kind of important metrics for people on that register. So how many have a CHA2DS2-VASc of greater than or equal to 2, for example, and are not on an anticoagulant. Now, we've got the filters up at the top here, which we can use to filter down that list, because at the moment we have 87 patients on here, and we might want to focus on a specific set of metrics to kind of work on that day for a particular recall, for example. And it might depend on who's actually using the tool that day for what specifically they want to do. You also have for each patient an overview of key parameters for that patient, so some demographic data, and then alongside things like medications they're on, relevant clinical scores, and other kind of cardiovascular risk factors. So whether they've got cardiovascular disease, hypertension, what their latest blood pressure was, and when their last medication review date was. Now, how you might actually use the tool, you can do that for various different things. So, for example, we might want to look at people who are on anticoagulation by just clicking the no anticoagulant button, and that filters down that list to 23 patients here. And then we can look at those with a CHA2DS2-VASc score greater than or equal to 2. And it combines those features. So now we have a nice list of 11 patients who are not on anticoagulation with a CHA2DS2-VASc score greater than or equal to 2. And we can do a few things with that. We can either export that list out as an Excel sheet. We can export it for Accurate, say in certain circumstances, we might want to recall those patients or ask them to come in for something. You can export the list there. And you can then go into those individual patient records to have a look around. I'll show you just some other kind of combinations of filters just before we do that, just to give an idea of some other kind of key important use cases. So to reset the filters, then you just press this reset filters button and it goes back to your full list. Another group of patients you might want to look for is your patients on warfarin, to think about, might these patients benefit from a switch to a DOAC? So you could either look for the full list, or you could look for, well, who's on warfarin but is actually probably due a medication review now. So then you can look for those, and you've now got a list of 3 patients, which is then a bit easier to manage than the full list of your AF register. Another kind of key group you might want to look at is people who are on an anticoagulant and are also prescribed an NSAID that isn't aspirin or low dose aspirin. And you can do that for both DOACs, and you can do that for warfarin as well. And you might want to review those patients just to check that that NSAID is appropriate, and that they've been cancelled on a risk, they've run a PPI, that kind of thing. So whilst the focus of this tool is obviously around atrial fibrillation, there are other kind of key linked cardiovascular risk factors that you can look at and review as well. So, for example, you could look at people with cardiovascular disease, diagnosis, so whether that be they've got ischemic heart disease, they've had a stroke, they've got peripheral arterial disease, that aren't on a statin, who have a high blood pressure, for example. So you could look then to find some further information about those patients. To actually, so you get an overview on the overview screen, but you can also then click into that patient's kind of more detailed records to give an overview of key important metrics for that patient. I'll just zoom in a little bit just so it's easy for everyone to see. So you have demographic information at the top. Again, just remember this is dummy data, not real patient data. You have information about their medications that they're on, so what they're currently kind of prescribed, when that was last issued, and the name of the medication. Now remember, this list of medications isn't completely exhaustive, so this tool is designed to be used alongside the clinical record rather than being used completely separately from it, but it just allows you to get all the key important features in one easy to use place. So as well as anticoagulation, looking at other things like aspirin and other blood thinners, and antiplatelets, whether they're on a PPI, whether they're on an NSAID and statins. It allows you to look at their risk scores. So if within EMIS you have entered their CHA2DS2-VASc score or their ORBIT score or their HAS-BLED score, the tool will then pull those through. It also gives you information about how to calculate those scores. So if, for example, a patient hasn't got an ORBIT score, you can calculate that and easily add that into the record. We then have kind of lists of comorbidities, and these are grouped into sections to make it easier to see. So if they have any of these comorbidities, they will be then listed at the side here and flagged that they have those, as well as whether they're kind of on, whether they have dementia, whether they're on the palliative care register, whether they're housebound. So just important metrics to just help you kind of review that patient. There are then other results and physical parameter measurements as well. So obviously this patient's not going to have an INR measurement because they're not on warfarin, but if they were, that would pull through if it's been coded in EMIS. You then see the latest blood pressure that's being coded in EMIS, that will pull through, as well as other important metrics like their audit C score, their renal function, their creatinine clearance that has been entered onto EMIS as well. as well as other important blood test results and a weight to help you kind of have all the things you need if you then need to plug some of those details into a creatinine clearance calculator, for example, if you're doing a DOAC review. It also gives you when their last medication review date was, which we can filter on the other screen, but also is just handy to be aware of when you're looking at this, as well as some important kind of exception reporting about whether anticoagulants have been declined in the past or whether they've been contraindicated. And it'll show you the latest code that's on the record there indicating those. So that gives a bit of an overview of kind of how the tool looks. I think we've got a bit more of the presentation now to come back to.
Thanks, Mike. I'm going to get my screen sharing again. So that's very useful. I think one of the key things I think most people are interested in is how this works and how it operates, and I think it'd be good for us to be able to go through some questions with you afterwards and maybe have a bit of back and forth as well.
Absolutely, yeah.
So the key here is that, and I think as I said before, is that the APL-AF tool is a supporting element in that it is integrated into this golden thread of the pie chart I showed you earlier of the different things that go into how we use the clinical effectiveness approach. So it's very important that we have high quality data so that we're able to identify the patients who have AF. We identify their blood pressure levels, their medication usage, all of that then feeds into the tool, but allows us then to can see what's happening within an individual patient or the population within the practice to understand what is happening there. So that data comes through those data entry templates to ensure that high quality coded data is able to be drawn on by the tool. And then with that, one of the things that we often find with any tool, any technology, anything that we implement, it needs support. It needs guidance. It needs someone to answer those questions about how things are working, troubleshoot, go back over things that we've talked about today, look and explore how things work. And that's the support that's being provided by our facilitators. That's that one-to-one guidance, that support within practice for training, for help on troubleshooting, etc. But this all comes together as that package of support as well. We have with that, although also some step-by-step user guides. These are available on the website, and the link is there. They go through about how to record the anticoagulation, for example, prescribed by a third party, not necessarily by the practice. It also shows how to troubleshoot the Excel files. Are we aware that there are issues around enabling macros? And this shows you very clearly and simply how to solve that issue. And that's in that reference there for you to be able to troubleshoot and address as well. So what to do next? Well, the first thing is, if you haven't already got the tool, request it, and we'll put the link in the chat. Hopefully we'll put that in there as well. Otherwise, you'll be able to see that on the website as well, where there will be additional guidance on recording the third-party prescribing or any troubleshooting. The other key thing there is to utilize our templates to code the activity correctly so the tool picks it up. The other key thing with our template is that it combines the codes that you need to achieve your indicators. And one of the problems that we often have is that there are national indicators that you need to be able to code for, and there are local ones together. And our templates bring together all those codes, so they make sure that with one code entry that it matches between the national and the local, so that you're only using the appropriate codes to make sure that you're accurately recording the activity, not only to show that this patient's health is being addressed, that you're managing their AF and their anticoagulation, but also that you are then making sure you're getting the right payment for the work that you're doing. So utilize the CEG templates to make sure that you're getting the right codes to match together and make sure that you're getting the right payments, but also that the tool is able to pick up the right information. But if you have any queries about that, if you need any help with the downloading or using, if you want more training, if you want some guidance about how this is going to work for you in your practice, please get in touch. We've got our facilitators ready and able to help support. If you can either contact us through our generic email address, you can use the QR code there, but we've got the list of names of the individuals who are able to support in each of the boroughs. I'll leave that up for a little while, and if people want to, they can scan that QR code to find out more about us and to access the website. All of our facilities are trained in the use of APL-AF, but there's more that they can offer as well in terms of how to utilize the additional tools that we have available. All of our templates that are around things around how to maximize achievement of the indicators, around how to improve the workload and workflow within the practice. It's a great resource there. I'd highly recommend getting in contact with them to talk through how to use this tool and anything else for troubleshooting on using our tools, our searches, our templates. Okay, I'm gonna leave that there. I'll stop sharing. That's the last slide. So in the chat, you'll hopefully be able to see the links and the AF tool form as well. So there is a question from Ben. Can the search out be listed by usual GP, thus making this a clinical tool, or does it just list whole practice data as with the CKD tool? Mike, so does this show the usual GP?
So this tool doesn't by default pull through the usual GP data. So we had feedback from practices that not all practices use a kind of usual GP. If you wanted to have an output just by GP, you could have someone at your practice just make an additional search just before, just to filter for patients whose name GP is Dr. X or Dr. Y, and then run the main AF search off that. By default, though, the tool doesn't look for regular GP.
I think this is something that we can look better to understand how things work in practices, and that's part of the adaptation that we have through working with the facilitators within the practice. So Ben, it'd be good to be in touch with after this about how we can make that work best for you within the way that your practice works. If there are any other questions, please pop them in the chats. We'll give you a minute or two to go through. Mike, do you mind putting the tool back up?
Yeah, no problem.
So one of the things I thought would be helpful, I think Mike's given a bit of explainer on this already, but it would be the key here is thinking about how this works in your practice. In some practices, this will be run by the GP. This will be the GP mainly looking at this. In some, it may be the practice manager or the nurse or the pharmacist. There's a number of different ways in which you can look at it. One of them is to run this on a semi-regular basis. That could be on a monthly basis to have a look at your list and to identify how many people are, for example, having had their CHASRAS score done, whether they're on a anticoagulation coagulant or not. If we look at that, so we've got this is the proportion of people who have a CHASRAS recorded in the last in more than the last 12 months and who are not on the anticoagulation. So, and also those that now are the ones who are not recorded. The key here, and I think one of the things I wanted to emphasize is the part here is about managing the workload within the practice. This is I don't see these as tools as things that are looking and managing the performance within the practice. It's about how we do the things that we need to do and how do we best streamline the way that we work in the practice. Because when we go back to that original list, one of the things I think we can be very daunted by is how many people there are on there. And we can talk about prioritization or risk stratification, but I think for the practice, it's about how the practice identifies the people that they think are the ones they need to work on next, and how that fits in with the way of working there. And it may be that there's an exercise, for example, to identify all those people who haven't had a recent CHASVAS done, like with these three here, and then that's the workload there. Is the first step is get a CHASVAS score done. And then from that, it may be to move next along and look to see about the orbit score and looking at see when that was recorded and identified, and then how that conversation then happens with the patient to then talk about anticoagulation as needed. That is supported by the call and recall function, which we now have the ability to generate a list for ACURIX, so that you're able to import that and support the call and the recall. There are other parts in there as well in terms of the prioritization. So thinking about, are there different population groups that we want to focus on here? Is it something that maybe this is something that we need to think about for our SMI population? For me, that goes back to that monthly running of the data. So what does this data look like, but what do we want to, in the discussion within the practice, want to prioritize for this round? Do we want to do everyone? Are we going to be able to look through all those numbers of patients in that month? Is there something there that we need to think, right, well, this is a particular exercise that we're going to do this time? And Mike's kindly handled the housebound. There might be something there that we think, for example, we need to task the district nurses to do bloods on, or that we want to think about having our HA or nurse or pharmacist going out to visit these patients, or to have a dedicated clinic template that allows you to have telephone consultations with them. I think what I'm trying to explain here is that there is something there around how you manage the way in which your practice as a whole operates, that allows the facilitation of this tool, or the Apple Renal tool, the Apple IMS tool, how that fits in to streamlining working and working efficiently. I'll stop there because I think I can see something in the chat. Shahid, thanks. So development request can be a facility for monitoring renal LFTs, full blood count for DOAC patients. Just a quick thing around development requests. So this is something that we are keen to take input on in things of how we develop our tools. There's a significant amount of work that goes into each of these, and so while we want to get that feedback, it may be some time before we're able to actively say that this is something that's going to come into them. But it's important that we do get that feedback of how things work as well. Mike, do you want to take that first one around a facility for monitoring renal LFTs, FPCs for DOAC patients?
Yeah, absolutely. I can't see the chat from here because I'm sharing screen. Was it just what was the? Let me just see in the chat.
So I think just to clarify, so he wants was suggesting a reminder dashboard, individualized with people's last renal function. I think if you go back to the patient view.
Yeah, so if looking on the patient view at the bottom here, so it has all the information about when their last EGFR was, when the last manually calculated creatinine clearance has been added in, or if you've used one of the creatinine clearance calculators within EMIS, that will be brought up within here as well. So it'll give you an idea of when that was last done. Certainly from a development point of view, we can look into potentially around filtering based on that. Something we can certainly look into. LFT then information, so we bring up the latest ALT or AST in here as well.
And so there's an option to be able to see for individuals as to where their last one was done. I think we need to think about what is the most efficient or best way to be able to identify people who need to have further bloods for recall. So that's a good point and a good comment. And there are other things that we are looking at in terms of how we are doing monitoring for medications as well, and that may sit alongside this. And I think will be hopefully some options in the next in the future about how that can be supporting practices with their recall for phlebotomy or for got other forms of the annual review checks as well. So there's an option there. The key also, though, is that this needs to sit alongside EMIS Assistant 1 open for people to be able to view what's happening with that individual patient, so that we've got the whole picture for them. And one of the things that you will see when you have your electronic health record open is whether they have any future appointments booked or whether there's something that need to come through as well. Does that answer your question? Hopefully it does. And I think it's the key here is that we do want to get more feedback for people in terms of developing the tools as well. The other thing also, sorry, Mike, was back onto the main page.
Mm-hmm.
On the right in the summary.
Yeah.
Could you just show that again?
Yeah, let me just zoom in so that you guys can see. So you get a table here kind of with the summary information. So everyone that's on your register, and then that's broken down by various kind of key subgroups. So people who have a great CHA2DS2 greater than or equal to 2, who have been on a DOAC in the last 6 months, for example. There are some slightly, so we link in with some some QOF indicators, but we modify them slightly just to take out some of the exclusions, just because it's kind of it's a little bit better for reviewing within the tool. And that will stay like this regardless of how the filters are set. So this will always stay the same.
So the crucial part here is that this is helping support the practice in identification of patients who, for your population as a whole within your practice, of patients who need to be issued their anticoagulation, who are on both anticoagulants, for example, or people who are on DOAC. So that helps you in terms of your population management, and the 2 QOF indicators that are included in there, those modified QOF indicators. This allows you to identify your performance against QOF as well. So this is supporting how that practice does the QOF achievement, but alongside the overall AF patient management. Okay, just picking up a couple of questions in the chat. So this is the latest release is version 4, which is the one that we're hopefully demonstrating today for you as well. So yes, version 4 today. And please get in contact if you don't have version 4, so you can get the latest version to get access to all of those new facilities and new codes within there.
So there's a good point from Carol in the chat there, just about a generic kind of point just about all the APL tools, and just us listing what the latest current version is on the CEG website. I think that's a great idea, and that's something that we'll take forward.
Thank you, Carol. Yeah, but very good. We will definitely update that and make sure we've got all the latest ones. There will be more hopefully coming out soon, so it will be good to be able to update that and have a place for us to be able to show not only the tools, how to use them, and how they all work. Any further questions? So John's put in that around our QOF achievement. I'm just going to read it out. So it's noticeable that for the first time, the QOF achievement for anticoagulation in the ICB is now over 90%, best in London and second best in England. So that's remarkable, and I agree, this is pretty remarkable given the complexity of our population. So well done to everyone who has been working on that, has taken that forward and shown the improvement on a key aim in our population. So this will hopefully help reduce down those AF related strokes and help to provide patients with a reduced risk of a disease that has significant morbidity as well as mortality. And just again to flag out John's tip this out to the pharmacist, and that was, yes, absolutely, particularly supported by the pharmacist support. So thank you to everyone, many of you who are here today working as pharmacists or within the medicine management team, who has helped to drive that forward. So well done. This tool helps support that in the continuing monitoring and assessment of patients who have AF who either need to be on anticoagulation either newly or continuously, to help to monitor the use of anticoagulation and help to manage or monitor their overall cardiovascular risk. So this is the tool that will help to support to continue with that achievement, and something that we'd hope to continue to improve upon, and help to again continue to provide good quality care for North East London. Mike, Krishma, any last thoughts?
If no one has any AF specific question, I'd like to come in just in general around the APL tools. First of all, thank you to everyone for using our tools. And we try our best to make sure that before release, we do a lot of testing in pilot practices to ensure that it's working well and there's no issues before we release the final version. However, we do appreciate that because different localities have got different hardwares and softwares, there have been times where practices have experienced difficulty enabling macros. In the chat and in the as Chris has pointed out in the presentation, we've recently produced a document that allows you to do the initial first steps of troubleshooting and overcoming. One of the main things that we say to ensure that you've enabled macros, but if that's rarely that doesn't work, but if there's such a situation that it's not working, we do recommend taking it a couple of steps further and adding the document into your trusted document list or in a trusted location. We've got a screenshot guide on our website and in the chat. But if there are any issues, please do not suffer in silence. Get in touch with your primary care facilitators or with myself, and we'll be more than happy to come out there to look at what are the problems. We are in talk with the NEL ICB IT team to ensure that going forward we have a sort of overall solution or uniform solution, and you guys don't have much issue using the tools. But yeah, that's all I wanted to say.
I just want to kind of echo what Chris has said previously. We make these tools because we want to make your lives easier. So if you have ideas for things that would make the tools better or make them work kind of better for you, please do just kind of reach out to your local facilitator and let us know. Then we can look at how we can integrate kind of those ideas and how we can improve and bring the tools forward.
Thank you both, and Shai, that's a good suggestion as well. And I think we need to work with our PC and our borough ICB colleagues as to how that will look and how we can take forward the reporting into other areas. So it's a good point around how we link in that data to the places that we need to. So thank you for that. Okay, I think we've covered a lot today. Thank you for everyone for your attention and your time. As I said, this is being recorded, so it will be able to be seen afterwards for anyone else, but also please get in contact with us if you have any questions, queries, any suggestions for this tool or others or future tools. I'm happy to listen and take suggestions for things that are going to help you with your work, and be keen to help to improve that efficiency, but also improve the achievement of better care in North East London. Thank you very much. Thank you to the team, and we'll see everyone soon.